Good evening, Doctor. I, Shuman, on behalf of Shield Healthcare, welcoming you all in today's webinar. And the topic of today's webinar is respiratory illness in children, prevention and management. And our guest speaker is Dr. Somnath, sir. Before moving into the webinar, let's have a look on our Shield Connect page. This is our Shield Connect page. This is basically a knowledge sharing platform of Shield. Here you can find different blogs written by many eminent doctors across India in different topics. And these are the first webinars already we have conducted in our platform in various topics as well. And this is the most important blogs, that is COVID-19 awareness blog. Here you can find different articles related to the COVID-19. And these are the most important thing, as that is key opinion leaders. Almost 250 to 300 doctors are currently supporting us this knowledge sharing platform. And now it's time to start the webinar. And it's our honor to introduce Sir. Sir did his MBBS from Bankura Sammilani Medical College and Hospital, West Bengal, a diploma in pediatrics DCH from the West Bengal University of Health Sciences. Sir did his MD in community medicine from All India Institute of Hygiene and Public Health under WBHS, and Sir is trained in pediatric advanced life support PALS and in essential newborn care in the year 2011 and PALS again in 2017. As I is presently attached with Life Care Nursing Home and Swasti Nursing Home. And Sir is the lifetime membership in Indian Academy of Pediatrics. Is a life member of Indian Academy of Preventive and Social Medicine, lifetime membership in Indian Medical Association as well. And the area of interest of Sir is neonatology and pediatric nephrology. So with this short introduction, I request Sir to take over the session. And meanwhile, I request all the participants for their active participation, and please post your queries on the QA dashboard of the Shield Connect page. So once the webinar will be over, we shall have a short discussion on this topic with Sir. So thank you, Sir, and over to you, Sir.
Yeah. Good evening to all of you. So, I'm going to present the topic of respiratory illness in children, its prevention and management. This is a very common topic day and day even practice. We are getting these sorts of ARI cases every day, and now it is the monsoon season, so it is a flare up of the cases. And after in COVID situation, we also get the cases of COVID in ARI cases. So it's a very common topic, and all we know the common facts from a very early days of MBBS. But I am going to just to again to recapitulate and the known facts to you, and all of you know the very good these topics also. So basically, it is a acute infection in children, and these respiratory infections are classified according to the involvement of the areas. That is upper respiratory tract. Upper respiratory tract involves nasal areas of nostrils, the oral areas, the pharynx, and up to the glottis of upper respiratory tract. And from glottis, it is the up to the bronchi, bronchioles, and lower respiratory. So infections are also mostly of upper respiratory infection and lower respiratory infection classified. And we are day by day we are getting more and more cases of upper respiratory infections, and are slightly predominant in cases of OPD visits than that of lower respiratory tract infections. So the common upper respiratory infections in children are of acute nasopharyngitis, that is of common cold in rainy seasons, in winter season, in summer, in frequent situation. The common cases of rhinitis are there. So it is a common cold is always there. It is mostly of viral origin, and also there are getting cases of pharyngitis, including tonsillitis, because tonsil is the first line of defense of the in our respiratory tract. So the inflammation of the tonsil is very common, and we are getting more and more cases of tonsillitis in these days. And also there is otitis media is not a very uncommon disease; it's also a very common disease, especially in children. So the common lower respiratory tract infection in children are we are getting bronchitis cases, we are getting bronchiolitis. We are also having day by day increasing incidence of bronchial asthma, And especially the today's in India, so much pollution is there, so much allergic challenges are in our environment. We are getting more and more cases of bronchial asthma day by day, and also pneumonia. But surprising fact that the most deadly disease is pneumonia, and by the invention of the vaccines, we are able to decrease the incidences of pneumonia in our these days. But still, it is also a deadly diseases, and also in the COVID pneumonia we are faced with our first wave and second wave. The COVID pneumonia was there, and we know what are the deadly consequences of COVID pneumonia is there. So this is also a lower respiratory medicine. So what are the factors affecting the type of illness? First is the age of the child. So the in our from the early days, the neonatal period, the new inflammation and the neonatal period is very critical. We always we always want to manage the respiratory severe respiratory cases of neonatal period in the hospital, not in the OPD cases. So the age is very important. Older the age, better the outcome in most of the cases. But lower age is and also is very difficult. And the frequency exposure, the exposure to the hot and humid environment, exposure to the dust, exposure to the allergens are very important for infection, developmental infection. And also the development, the size of the airways, sometimes having congenital anomalies in the airways is there. So ability to resist the invading the organism, the uh, each individual, each person having the separate sorts of defense mechanism in their body. So individual defense or individual resistance to the organism is different. So the level of body's ability to resist that is of immunity. So your immunity, your defense is of prime importance. So each in cases of malnutrition, in case of congenital heart disease, in case of anemia, in case of immunodeficiency, these sorts of defenses are bared and hampered, and showing the lower resistance to the infection and having to prone the body to have the infection. And also the presence of respiratory disorders such as allergen, worsening in the cognition. So seasonal also is very important. As I told that in rainy season, in the damp and humid environment, is favorable for the development of the viral infection. And once the viral infection predominates the body, once the virus breaches the body, then it is the bacterial infection then it can become easier for the host to invade the body. So it's of very important is that in environment condition is when we should have focus as in the winter season, in the rainy season, the more chances of respiratory infection is there. So etiology. So mostly it is of viral etiology, and mostly in cases of there is no treatment for the virus etiology, and it mostly subsides some sorts of time. So viral environment, we are having the environment, most of the viral cases are there, as well as the influenza is the predominant virus, the parainfluenza is there, the rhinovirus is there, all the adenovirus is there. So there are many viruses in our environment which can cause easily the host defense. And nowadays the called COVID vaccine is there. And we all know learn from the COVID cases that it is of COVID infection is first 7 to 8 days is having upper respiratory infection, and then becomes it invades the lower respiratory tract. So then after infection of the organism, the bacterial infection sometimes predominate. So other organisms are secondary infection are sorry of beta hemolytic streptococcus, Haemophilus influenza, that is H influenza, and the pneumococcus. So these are the three main bacterial infection of the upper respiratory tract and lower respiratory tract infection. And infections are often localized to the single anatomic structure. It often fails to spread the extent as a result of the continuous nature of the mucous membrane lining the respiratory tract. That is, sometimes we often do not clarify that the infection is only in the tonsil. Sometimes it invades the ear lobes. Sometimes it invasion in the middle ear and it cause the infection of the tympanic membrane, and often it spreads lower in the larynx, Sometimes the infection from the larynx crosses the barrier and makes the laryngotrachea bronchitis cases. So it is often we see that it's not a very localized infection, but sometimes it is a more spreader infection. As in case of newborn, the membranes are very permeable, and so the spreading severity of the virus defines that it is of upper respiratory or lower respiratory. So most of the URIs are caused by viruses and are self-limiting, as I told that. It is a we are having most of the cases of viral infection, and the only some saline inhalation, some saline gargle, or sometimes saline vapor, often the skin and skin often resolves the symptomatic relief. And sometimes we have to treat the antibiotic drugs like paracetamol to treat the infections, or most of the cases. But rarely these are the very severe infection indeed. And also acute nasopharyngitis or pharyngitis in tonsillitis are extremely common in pediatric age group. So nasopharyngitis is basically the common cold that is known as a common infection of the rhinitis from the nose. The sneezing is there, some watery discharge from the eyes. It's a very common in common conditions, and often having fever, often having irritability, often having abdominal. Sometimes is pain abdomen is there, sometimes vomiting is there, sometimes fever is there, dryness, and in the younger child, and in the older children, dryness, irritation of the nose and throat, sneezing, and muscular aches are there. So it depends on the age of the child. The what are the complications? In the sometimes we know that recurrent nasopharyngitis, recurrent common cold viral infection causing otitis media. That is sometimes at acute otitis media is acute infection of the middle ear lobe. Sometimes it is causes recurrent respiratory, recurrent ear infection, or recurrent secret otitis media is there. That is secret otitis media due to the anatomical structure of the eustachian tube. The younger children are more favorable having development of the ear infections or ear secretion of the middle ear. So, and also sometimes it invades the host events and causes the lower respiratory infection. Sometimes the secondary pneumonia may be there. In older children, you may develop sinusitis, chronic sinusitis, or acute sinusitis if they are having pain in the sinuses, or having acute headache, acute dizziness. So these are the some facts of sinusitis, and the treatment is, as I told, that the saline gargle or steam inhalation, or acetaminophen is the antibiotic drug will often used for the treatment of the sinusitis, the problem with headache, or maybe a fever. So, what is the treatment of pharyngitis? It throat culture sometimes very helpful for us to detect what the type of organism is there, and the antibiotic we should be focused regarding the treatment of the streptococcus, that is group B beta hemolytic streptococcus are mainly focused the for the treatment of severe pharyngitis infection. Sometimes viral pharyngitis is there, and which is very minor infection. For bacterial acute suppurative pharyngitis or tonsillitis, sometimes we have to treat the treatment of streptococcal infection. So antibiotic medicine should not in terms of viral infection, but suddenly some severe pharyngitis cases or some severe infection of like beta similar streptococcus need antibiotic. But most of the cases of viral infection, that is there is no role of antibiotic for this minor cases of pharyngitis having viral infection. Health of the child is raised as much as possible. There should be smoke-free environment from the in the to be given in the child. If the child's throat is very sore, he or may not feel like eating or drinking very much, soft foods or some warm soups may be there. These foods may feel good going down the child's throat where it is very sore, and give this child 6 to 8 glasses of liquid like water and fruit juices each day. Run a cool mist humidifier in the child's room. If the child is 8 years or older, ask him to gargle with a mixture of 1 psi salt in the 1 cup of water. So saline water is very triple cost than that of medication with water. So what is tonsillitis? As tonsils is the basically the gland, the lymphoid tissue, the first defense barrier of the respiratory tract is the tonsil. and where large number of lymph tissues are there. So tonsillitis is very common when in the seasonal changes. Tonsillitis is a viral and bacterial infection in the throat that causes inflammation of tonsils. Tonsils are small glands, lymph tissue in the pharyngeal cavity. It is the first 6 months of the life of tonsil provide a useful defense against the infection. Tonsillitis is one of the most common elements in the preschool children, but it can also occur at any age. Children are the most often affected from the around the age of 3 or 4 when they are start nursery or school and come into the contact with many infections. A child may have tonsillitis if he or she sore or fever or the foot. So you see the diagram, the beautiful diagram showing the enlarged tonsils involvement of the uvula as well as at the pharyngitis. The again is mostly having child having severe throat, severe pain in the tonsil, especially the glands are visible are mostly of paratile tonsil. Sometimes in cases of we often notice that some cases of pus may be there, some erosion may be there. If there is pus are noticed, it is called as acute suppurative tonsillitis. So, so what causes the tonsillitis? Tonsillitis is caused by a variety of contagious viral and bacterial infection. It is spread by close contact with other individuals and occur with more during winter period. The most common bacterial infection occurs during winter periods. The most common bacterial causing tonsillitis is Streptococcus. As I use the beta hemolytic Streptococcus is the most common culprit in tonsillitis cases, especially of acute suppurative tonsillitis. And sometimes the white patch is not completely here, but sometimes we in our previous days sometimes the white membrane on the tonsil or pharynx is very important to rule out there is any bacterial infection is there or not, because bacterial infection is a life-threatening infection. But if we see a white membrane is there in the tonsil, we should be referred to the higher center to for the investigation regarding the cases of having diphtheria or not, because diphtheria is a very life-threatening infection. So you should be careful of that. So the advice and treatment is encourage the bed rest, introduce the soft liquid diet according to the child's preferences, provide cool mist atmosphere to keep the mucous membrane moist during the periods of mouth breathing. Warm saline gargles and paracetamol are the useful to promote the comfort. If antibiotics are prescribed, counsel the child's parents regarding the necessity of the complete in the treatment period. That is the duration of the treatment is very important. The 5 to 7 days therapy should be there. Some often we seen that the child is not able to not like the taste and the flavor of the antibiotic, and often we found that half dose given and or sometimes they are not complete of the full dose course. So this may cause the relapse of the infection in the future. So the course of the and the duration should be explained to the parent regarding the duration and the complete therapy of the antibiotic. And also we should explain the patient that not to give these sorts of antibiotic regularly without the prescription of doctors. Sometimes we see in our OPD practices that in case of acute pharyngitis cases, recurrent pharyngitis cases, the same antibiotic parents are using 1 month regularly. So these are very culprit the situation, and more the complex, make the more complex of the situation in the future. So tonsillectomy basically is the last option is there tonsillectomy. If there is more than 4 attacks in a calendar year, there's more than 4 attacks of acute suppurative tonsillitis is there, then there should be considered for the ENT surgeons to have the opinion regarding the tonsillectomy should be done or not. Surgery might also consider if the tonsils were too large that causing breathing problems at night. So this is the last resort of the treatment of the tonsil. So also otitis media, so we are commonly facing the brain, some viral infections maybe they are in the middle ear, causing the pain in the tympanic membrane. There is bulge of tympanic membrane is there. So basically the otitis media is the second most common disease of the childhood after having upper respiratory infection. Is the inflammation of the middle ear. It is having viral infection maybe there, some acute bacterial infection maybe there. Specifically, the origin of the infection mostly is from the throat, not from the outside. Outside, mostly the parent thinking that they are the nature of the infection is from the outside to the environment and going to the infect the ear. But the fact is that it is mostly having the eustachian tube, the structure of the eustachian tube, which favors the infection from the in the children from the throat to the middle ear. And otitis media can be classified into the many varieties of the etiology, duration, symptomatology, and physical features as the following. Acute otitis media implies the rapid onset of disease assessment over the one and more of the following. There is otalgia, having fever, sometimes having severe pain. We often facing in the infancy or especially around the child of 4 to 6 months or having severe acute cry in the night and after whole night he cry, he or she maybe cried, and after in the morning there's some sort of discharge from the ear. That is the rupture of the spontaneous rupture of the membrane and causing the otorrhea and relief of the pain, and the child is cool after the discharge of the membrane. So it is very common that the pain and the discharge and the irritability is very common in cases of acute otitis media, and we often discourage the parent to not to give bottle feeding because bottle feeding is often because of the infection of the in the throat and the eustachian tube, and we often give care of the nasal blockage. If the more the nasal blockage, more the chances of infection of the ear because uh, the effort the child giving is often precipitates content from the throat to go to ear. So nasal clear nasal drop should be there. So saline nasal drop basically you should prescribe to clear the nasal cavities frequently. So it is also a beautiful diagram picture showing the inflammation of the tympanic membrane. It is showing that the tympanic membrane is inflamed, tympanic membrane is bulged out. So it is a classical picture of acute otitis media. It is often causing opacity, edema, and sometimes failure infusion is there. Urinary infection of any duration that cause associated with signs and symptoms of infection of the fever, otalgia, irritability, otitis media usually follows the episode of otitis media infection as previously told that sometimes after the subsidence of the bacterial infections, maybe the recurrence of the otitis media causing serious discharge from the serious the infection of the otitis media. So it is also very common in children. Sometimes it's the recurrent RTI cases, recurrent OURT cases, recurrent allergic rhinitis cases. We are facing these sorts of problem, recurrent ear pain, recurrent ear infection, recurrent ear discharge, maybe they are. Sometimes we have to put the gromate insert the gromate to to relieve the effusion. This large effusion is there, so gromate insertion sometimes done to relieve the stress otitis media. And also other varieties, monocytitis media, where recurrent inflammation, recurrent persistent miliary infection for more than last at least for 6 weeks, and it associated with the tutorial throughout a period of timbering event, whether the timbering member is ruptured for last 6 weeks, and then there is sometimes the chronic discharge from the ear is there, but there is the pain in the acute phase is not there. The discharge is persist. The smell is also not that of the bloody discharge is not often there, but the pain is the typical pain of acute otitis media is not in present in cases of steroids and in cases of chronic otitis media. This is a defining factor. And in case of chronic otitis media, it is mostly managed with the ENT setup with the tympanostomy or there. So this is the case of chronic. This acute and cool and diffusion we had the bulging tympanic. What are the therapeutic management? Specifically, in analgesic and antipyretics should be there. So in most of cases, we are treating with the use of paracetamol in the most of cases, and also the saline nasal drop, as previously told that sometimes with the older children, the gargle is very useful. Apply hot water back over the child's lying on the affected site and reduce the discomfortness. For draining air, external air can be frequently cleaned using the sterile cotton swab. Dry or soaked in hydrogen peroxide sometimes useful. Excoriation of the outer ear should be prevented by frequent cleansing and application of the zinc oxide of the area. Give special attention on the tympanostomy tube, that is about the water entering into the middle ear and introduction of the bacteria. So the hygiene of the tube should be explained to the patient party. Educate the family about the care of the child and keep them away with the potential complications of acute media. It's not is sometimes the life-saving condition of cognitive hearing loss is there. So the hearing loss is in cases of moderate media is cognitive hearing loss. So it is often persists for a few days and in cases of infections. So it also care should be there. Now move towards the lower respiratory tract. So the most common by an anatomical position, the common is the croup syndrome. That is the fever with acute bruxy type of coughing. Sometimes like that of Parkinson's coughing, the fever type of cough. Very often also is found in case of croup also there. With the brusky or the dry or the hissing cough is there. Acute larynx infection of the larynx characterized by the severe involvement of the voice. Breathing pattern sometimes is hampered following the clinical picture of hoarseness of the voice, resonant cough, varying degrees of respiratory distress. The croup symptoms are usually described according to the primary atopic area. That is the it is where it is often involved larynx, laryngotracheobronchitis is a common term for explaining the croup. That is the origin of the infection. So we often in cases of croup there is distress in this there, and the child after 3 to 4 days of viral infection having basket type of coughing, and these sorts of infections are very troublesome for the babies. So we should be very careful. Most of the cases are nebulizer with budesonide maybe have some relief, but the treatment of severe cases should be with cool moist oxygen is the main therapy. Sometimes it is the nebulized epinephrine with nebulization is sometimes helpful, and also by minor cases use of moist oxygen is there, but in severe cases we should be cases having life-threatening respiratory distress, some the saturation may fall. Like so, in those cases they should be hospitalized, and we should observe for there is any development of the severe complications like that if the saturation is falling or not, if the respiratory distress is of life-saving or not, and sometimes tracheostomy is endotracheal intubation sometimes done, but very rarely drug intubation or tracheostomy needed. But most of the cases are self-limiting, and usually the patient usually responds to corticosteroid therapy. So, another is the infection of the bronchus. That is the it is the acute bronchitis. That is it is a inflammation of the lining of the bronchial tissues that connect the trachea to the lungs. That is the organs of involvement of the brain. So this is the involvement of the bronchus. Bronchus becomes more thicker. So there is more distress in the lower respiratory tract. When a person has bronchitis, it may be harder for the air to entry into the lungs. That is normally would have become irritated and inflamed that other mucus produce. So large amount of mucus produced in the bronchus. And among the children, the condition is become worse due to the lack of the cartilaginous support. That is the in the older patients we have having the more cartilaginous support. In children, they are having the more smooth muscles. So these smooth muscles contract and in the more frequently than that of older. So the distress, the development of the freeze or development of the respiratory distress is much more common in case of children than that of adult. And adolescents having also this sort of. So basically, the management part is bronchitis is a mild and self-limiting disease that required only symptomatic treatment, including the analgesic, antibiotics, humidified oxygen, cough suppression sometimes there. But in most of the cases in our day-to-day practices, we are the bronchitis cases or the having some wheezy attacks. We usually avoid these sort of some cough suppression, but because of the determinants of the severe sometimes bronchial asthma flare up due to application of the cough suppression. So the cough suppression should be prescribed very cautiously if there is any history of severe attack of asthma or severe wheezy attacks in previous is there or not. But antibiotics are usually these are not very useful because most of the cases are of viral origin. The viral etiology is there. So bronchiolitis is also very common in our day-to-day practices, especially in the young children. We are having this lots of infection causing mostly of viral infections. This affects the teeny airways, the bronchioles, the bronchi are the larger airways, and bronchioles are the smaller airways. And also in children, it is mostly of smooth muscle origin. So they are very much fond of bronchoconstriction due to the changes of the environment. So the development of the respiratory distress, development of wheeze, or development of the acute lower respiratory infection is in there. So and also it is easily become more thicker because the development of the severe mucus secretion in the bronchioles, and also it is causing hyperpnea or prolonged. Sometimes the in epicematus condition is also there. The lungs become the air trapping is there. That means the air is trapped in the alveoli due to the development of the severe inflammation of the bronchioles and causing air trapping and also in epicematus lung condition and causing more distress to the children. So this is the picture showing the bronchial swelling. This in bronchitis, the way becomes obstructed and the swelling of the bronchial wall. So there is the during inspiration the air is passed very frequent, very smoothly, but during expiration the expired air need to be comes up from the bronchioles when it becomes obstructed in cases of bronchiolitis and becomes air trapped. So there is more distress in the children and the chest become expanded. In our if we done X-ray, there is expansion of the dizziness of the chest. Fortunately, most of the bronchial cases are mild. Typically, no specific treatment is there. Antibiotic is not very useful as most of the cases are viral infections. There is no role of routine antibiotic for this bronchiolitis. And suddenly, the most important part of the management of bronchiolitis is the more giving moist oxygen therapy is the utmost importance. And also, medication, some like bronchodilator, some budesonide inhibitor is also there. But I think the nebulizer is a very common in our day-to-day practices. But for giving nebulizer, we should also try to encourage that nebulizer should be given in the hospital setups with the moist oxygen because it should not be promoted in the closed room, causing more distress to the child. And it should be done with the oxygen to giving the more benefit to the babies. And but this stuff in the COVID scenarios, sometimes we are now giving bronchodilator as like aspirin or livolin to the special devices sometimes may cause some benefit. But mostly viral etiology and also the nebulization with 3% NaCl is often having some benefits because it decreases the secretion and it relieves very the symptomatic relief is there. To encourage bed rest, other small amounts of more frequent intervals should be feeding should be allowed. And those who are moderately severely ill need to be hospitalized, watched closely, and given the fluids and humidified oxygen. So pneumonia is the inflammation of the lung tissue. With exudate material is there. Sometimes we see in the lower consolidation is there. Involvement of the one part of the is there. So now the pneumonia is having high fever, patient having high fever, dry cough. The tachypnea is there. So it is very common. You see, this is the diagram. showing the pneumonia of the right side of the part of the lung. Sometimes in the middle and lower part is also affected. So pneumonia it should be managed with very cautiously because it is sometimes may cause some life-threatening infection, life-threatening disease. So it depends upon the condition of the child. It should be hospitalized. And the viral pneumonia, as you know, that it is sometimes viral pneumonia is there. As we people know, respiratory syncytial virus RSV is the most common causative organism. And nowadays, the COVID pneumonia is also these sorts of picture. If we see these sorts of picture, this, the COVID test should be there to rule out is there any COVID infection is there or not. And also many types of bacterial infections require hospitalization, usually accompanied with higher level of morbidity and mortality than the viral infection. That is Staphylococcus infection or influenza is a very culprit organism. So these sorts of organism is there. If the child is malnourished, if the child having immunodeficiency, if the child having congenital heart disease, these sorts of childs are very much favorable of the development of the pneumonia. And often we this recurrent pneumonia, we have to rule out the yes there is any foreign body inhalation is there or not, is there is a foreign body located or not, because if foreign body located causing recurrent pneumonia, sometimes recurrent aspiration, recurrent those patients with having recurrent GERD or regarding GERD cases causes recurrent respiratory infection of the lower respiratory tract also. So these sorts of things should be ruled out for the management of the part. And also the in management of the bronchial asthma is very common cases. First, there is recurrent attack of wheezy attacks, the recurrent wheezy bronchial attacks. In our respiratory practices, we stamp the child having the cases of bronchial asthma, especially after the 6 years. If we below 6 years, we usually do not stamp it as a case of bronchial asthma. Rather, we are trying to diagnose and it may be a possibility of bronchial asthma in there in life because of having recurrent wheezy attacks. But we should stamp it as case of bronchial asthma, especially after the age of 6 years. So it is basically a allergic condition. It's basically hyperinflammation of the lungs to the environment, hyperinflammation of the lungs to the viral infection, sometimes precipitate. So there is distress and dry cough, the night cough is there. So which recurrent, sometimes the patient having exercise induced asthma, the exercise having severe respiratory distress, especially after the laughing or dancing, having respiratory distress. Especially it is varies in the situation. There is history of thick mucus secretion, especially of the dry cough in the morning session also is there. So these are the very basic findings of the bronchial asthma. We should also find out the asthma triggers. There is also we know that the dust allergy is the most of the culprit of the asthma, and sometimes nowadays the cow milk protein allergy also having the responsible for the development of the asthma some cases. And information of the edema of the members, accumulation of initial secretion from the mucus gland, span of smooth muscles, bronchi and bronchioles are decreasing the caliber of the bronchioles and making more favorable for the attacks of the asthma. So basically, the therapeutic management is of asthma control plan. We are having GINA guideline is there. We are usually follow that GINA guideline for the information on the management of the bronchial asthma. It is mostly of medication of control of therapy is there and also reliever therapy. For reliever medication, we do beta agonist and is the reliever medication and inhaled budesonide, inhaled budecort or inhaled fluticasone. Some usually commonly used for the control medication. And also the most important part is the parental counseling and parental management, and also the behavioral pattern, the changing of the behavior of the child should be there. So these are also the basic education. Health education is the more key part, and also the maintenance of the large therapy, and also not to discontinue the inhalation, inhaled budecort and the frequent changes. So these are the main basic parts of the management of the bronchial asthma. And in case of life-threatening asthma, it should be hospitalized. It should be treated according to with some corticosteroids is needed, some syringe may be there, and also IV theophylline sometimes referenced in case of life-threatening asthma. So now there is some certain guidelines I am discussing regarding the WHO recommendation for the management of the ARDS. Clinical assessment, history taking, management are the very important. As I previously told, that age is very important factor. Feeding habit is very important factor. Fever is there or not. There is convulsion is there or not. There is irregular breathing pattern is there or not. History of treatment during the last illnesses, and also the activity of the child is very important. So physical examination, count the breaths in 1 minute. So breath count, respiratory rate should be there. Breathing count depends on the age of the child. The more than 60 for above the neonatal period, in the neonatal period for more than 60 days is of having tachypnea. In case of from 1 month to 12 months, the respiratory rate above 50 is of having tachypnea, and below the above the 1 year, the rate of 40 is the tachypnea rate. So after 40, the tachypnea. So which is basically a child with huge big soft tissue, listening noises, or shows signs that breathing out is difficult. These are due to narrowing of the air passages of fever. Sometimes which are more audible in the stethoscope. We commonly sometimes in severe cases we often we found the wheeze in our we are rare that easily audible the wheeze in the OPDs. Taking of the body temperature is there, sign of hypoxia is there or not, or there is fever or not. So, and the fact of malnutrition is the greatest risk of development of the lower respiratory and the fatal outcome of the each and every cases of the lower respiratory or upper respiratory. The malnutrition part is the most important process, and often in case of malnutrition, we should also treat the child very carefully because sometimes some sorts of open viral infection often landed into a very fatal secondary pneumonia later. So malnutrition part is should be dealt very cautiously. In severely malnourished child with pneumonia, the first weaning child withdrawing are not so much evident often, and then we should have be very careful for managing this sort of cases. And impaired or absent response to hypoxia and weak or absent cough reflexes may be there. Especially in case of cerebral palsy child, we having the more difficulties for the assessment of these sorts of pneumonia. There also careful evaluation and management should be there. So ARI control program involves an episode of acute symptoms, signs of resulting from the infection or any part of the respiratory tract and structure. It concerns 22 to 66% of outpatients and 12 to 14% of inpatients. In India, 10 to 50 children die per 10,000 episodes of ARI. So it is not a very common. It is very common. The class of the program to children we are in that the level of training of the field with the recognizable easily and readably and critical signs of ARE. WHO protocol converts 3 stages: case finding, assessment, and case classification, and issues of appropriate therapy. Cough, breathing pattern, and in the respiratory planning should be explained to the field worker to find out if there is any evidence of tachypnea present in this is not. Fever is not an efficient criteria. Breathing count is the most important criteria. And sometimes for evaluation, it should be explained that during the time of high fever, the normal usual respiratory rate is very high. So it should not be keep fever, during high fever cases, the normal respiratory rate is very high, and we should not think it is a case of tachypnea in that because after that the down of the temperature, often the tachypnea subsides. So these sorts of things also could be kept in mind. So children should be grouped into less than 2 months, having the more severe problems of having, and also from 2 months to infants. And previously, less than 2 months, pneumonia is a diagnosis with respiratory of 60 per minute without the clinical side. All should be hospitalized. All should be receive IV antibiotic. Minimum duration should be of 10 days, and the treatment of the ampicillin or gentamicin is provocated. This appropriate choice should be there. Breastfeeding infants exclusively no other food or drinks or not even water for the first 6 months of breastfeeding has excellent nutrition value and it contains the mother's antibiotic help to protect the infant from the infection. So, so breastfeeding, you should promote the breastfeeding. The more the chances of infection is less in this is a breastfed child than as a top-fed child. So avoiding irritation of the respiratory tract by the indoor air pollution, such as smoking, should be avoided, and the environment, the clumsy or the uh, population dense area should be avoided, and also immunization of the children during immunization program, and feeding of the child with adequate amounts of variety of nutritious food to keep their immunity strong. These sorts of things prevent the development of the ARI. Control the spread of the respiratory bacteria by educating the parents to avoid the contact as much as possible between the children and the parents who have ARS. People with ARS should cough or speak away from the others. I think the use of the mask is nowadays is abrogated and not only for the COVID cases but also the other ARI cases are decreasing day by day because of the use of the mask. Because we should encourage those patients who are having acute cough should wear a mask in front of the children, and also the deposit of the droplets from the sneezing, the proper hygiene should be there. Immunization also decreases the control by reducing the respiratory reservoir and infection in the community and increasing the level of the herd immunity. So the immunization part. The measles vaccine is a very revolutionary in India because in the previous the measles days by measles pneumonia is also a measles causing deadly pneumonia and sometimes measles cause a deadly diarrhea. So measles vaccination is very important because we are if we give measles vaccination properly, the chances of the severe pneumonia, severe diarrhea is becoming lower. So measles vaccination first in the 9 months and 15 months, and then the booster of MMR is at the 5 years. Also important vaccines. Government of India has incorporated in this part is the heat vaccine. Previously, in our MBBS career, we are having the schedule of having DPT infection and hepatitis B infection now, and then the government acquired the pentavalent infection, that is involvement of the heat vaccine included in the pentavalent vaccine. So heat vaccine also decreases the chance of upper respiratory infection as well as lower respiratory infection, and also have a major impact in the ARI control program because of the decreasing the incidence of the H influenza virus infection in the ARS. So it is given at 6 weeks, 10 weeks, 14 weeks, and 16 months as a booster dose. DPT vaccination, DPTs, diphtheria, pertussis, these are the common respiratory deadly bacteria. So by giving DPT vaccine, we are making the lower incidence of diphtheria and also the deadly diseases of the pertussis. So by providing DPT vaccine, we are now lowering the infection of these sorts of flu. And nowadays the boost fix or Tdap injection is given regularly in the higher status in the mother. So they are also aiming to focus in the incidence of pertussis in the neonates, decreasing the incidence of pertussis by giving Tdap to the mothers, and also is there. And also nowadays the flu vaccine is of focus. We are having recurrent those infections decreasing the incidences of influenza viruses infection day by day, and also influenza viruses in vaccine having covered the swine flu vaccine as well. So we can also control the swine flu infection in our community by giving influenza vaccines. It is given usually after the 6 months of age. First, we have to give 2 doses, 1 month interval, that is 6 months and 7 months, and then yearly you have to give the influenza vaccines. And then is the pneumonia vaccine. It is also a very important part in the management of the community of pneumonia because in, pneumococci are the most common culprits, and there are so many strains, so many variety of pneumococcus are also there. But out of these, now we are having PCB10 having two companies there. one is still produced by GSK, and also nowadays the new vaccine, there is pneumocil is there, pneumocil by Serum Institute, and also the most important vaccine of this is the PCV13. PCV13 has a more coverage of the strains of the pneumococcal. It is also having the breakage of the nasopharyngeal carrier, that is the 90K strain is there in case of PCV13. And also the PPV23, that is the pneumococcal polysaccharide vaccine. Pneumococcal polysaccharide vaccine is usually not advocated in the children. It is for adults. We are prescribing pneumococcal conjugated polysaccharide vaccine, because polysaccharide vaccine is one type and it is usually given to the adults. So that's all. So please summarize that ARI is a very common infection. We having upper respiratory infection, lower respiratory infection, and mostly having viral infections is there. So we should keep focus on the symptomatic treatment of the child, not to treat the virus and the bacteria too much, because mostly a self-limiting infection is there. We should care of the malnutrition, we should care of the health of the child, should care regarding the vaccination is there. We should either treat the asthma part is there. We should treat the allergen. We should avoid the planning of the health education should be there, and also we should provide the healthy health education to the parents to make the child more happier and more energetic in their life. So that's all. Thank you.
Thank you very much, sir, for this nice presentation, and you have covered that all the things related to the respiratory infection. Thank you very much. And sir, meanwhile, I received one two questions. So if you allow me, then we can move forward.
Yeah.
Okay, sir. One question is, sir, Dr. Jayalakshmi Madam asked that what is the role of antibiotics in viral respiratory?
Role of?
What is the role of antibiotics in viral respiratory infection?
No, there is no role of antibiotic in case of viral infection. We should give antibiotic to prevent the secondary bacterial infection after having viral infection. Sometimes the viral infection invites the secondary bacterial infection, and in those cases of having the suspect of secondary bacterial infection, this should be treated with antibiotic, not the viral infection. There is no role of any antibiotic for treating viral infection. But in case of COVID, there is no role of any antibiotic. Nowadays, the guidance has changed. 1 year back, we are prescribing Azithromycin as a case of treatment of the COVID, but nowadays the guideline has changed, and now the clear guideline is that budesonide inhaler is the drug of choice for treatment of the COVID pneumonia, because it's a viral infection. So there is no role of any antibiotic in case of any viral infection.
Thank you, sir. And another question is, sir, in your practical observation, how can you distinguish between the respiratory infection with some other problem and with COVID? You found a case. Is there any specific approach? Is there any specific approach to identify whether it is related to the COVID or other viral infection as well?
Yeah, in cases of COVID pandemic, we are also having cases of influenza, also cases of nasopharyngitis, also having these sorts of problems. But for cases of COVID, you should carefully take the history. Is their family member is affected or with COVID or not? Is there any travel history or there or not? Is the child is very much sick or not? Or if there is any doubt regarding the COVID, you should go for the test, because without doing any test or doing any RT-PCR, you cannot rule out a COVID from a simple viral infection of the throat. So you should be also be careful to rule out, because there is no clear-cut clinical guideline from COVID to non-COVID viral infection. But if there is any suspicion from your mind, you should do for RT-PCR test and rule out whether there is COVID is there or not. If there is no COVID, then you should focus on the basic thing. But if there is COVID is all, but the basic treatment or basic treatment protocol is very similar. You should treat the child and use antibiotic. You should have the hydration should be there. The body temperature control should be there, and also the basic nutrition should be there. The basic things are always management of the each and every case is there. So the management of common viral infection, the management of COVID, you also keep all these things very clear. And if there is any suspicion that this child may have some COVID due to the travel history or the family history, then go for the test, rule out if there is artificial test, and rule out if there is COVID or not. and then go for the treatment plan.
Thank you, sir. And sir, do you recommend any kind of nutraceuticals to prevent such kind of viral infection in pediatric patients?
Repeat this.
Do you recommend any kind of nutraceuticals to prevent the viral infections or build up the immunity for the pediatric patient?
Nutraceutical. What is it?
Nutraceuticals, sir. Any kind of immunity boosting material like curcumin or some other
Basically,
things.
immunity boosting. Immunity, you cannot increase the immunity in one day. When you getting cases of COVID, or when you getting cases of severe infection, you cannot push the body to have the higher amount of the immunity, because it is the ultimately the basic thing is that it is the hyper immunity responses of the hyper immunity which damage your own body. The basic management of the COVID, basic management, basic uh, physiology or basic pathology of the COVID is the hyperinflammation or hyperinflammation of the your own body. That is the your immunity system is too much active or too much damaging for your own body to damage your own lungs. So basically, it is not the immunity power to in a one day and making the COVID-free environment. It is the basically the day by day changing the environment. You should focus on the regular therapies. You should focus on the basic nutrition pattern. Sorry, the basic immunization, the basic history. Because sometimes in the last 2 years, there is so much delay in the immunization in our practical fields. There is so much delay in the immunization. There is so much delay in the basic health education. So basic things should be there. You should encourage your immunity body by day, not in a single day. When during COVID period or during any severe infection, just the requirement of the protein in the body, the give more proteinous diet, give more fruits in the diet first, on like that to tackle that situation, not to increase the immunity power of your own body, because immunity power is very much individualized and having long term from the feedback. The child having immunization acquired immunity from the mother. So you should focus on each and every person in our community to decrease the level of immunity of the whole community, not a single day. So we should encourage to giving more on the diet pattern, the nutrition the diet pattern, and also the nutrition pattern from beforehand, not in the critical illness.
Okay, sir. Thank you. And sir, in case of if you found a particular child having some viral infection, if you diagnose, so in that case, do you recommend any other kind of antiviral drug to that?
No, no. Basically, there is no role of significant antiviral therapy is there. Also in COVID cases, there is the debate is going on and whether antiviral therapy is to be given or not. Because the major is the anti-inflammatory drug, not the antivirals in the management of the COVID part. So basically, the treatment of the inflammation is there, not the antiviral. Because it is of no role in nowadays. For my personal opinion is that there is no role of antiviral for treatment of giving viral infection, because viral infections are usually will to subside, having the your natural immunity from the virus you have to gain.
Thank you, sir. And sir, my last question, which is very pertinent, maybe in recent future also. So, as we are on the verge of the third wave, as some data or some government institutions are suggesting, and we can see that it will be affect mostly the children population. My question is, as the previous research on COVID is suggesting that it will be based on the it will directly act on the ACE receptor, which is very less number in case of pediatric patient, pediatric group of population. So pediatric population doesn't got affected in case of first and second wave.
Yeah.
So what can be the reason why they are prone to be in the third wave? That's it.
Because one hypothesis is that the adolescent population are mostly vaccinated, so there is less chance of infection in them, and also in our second wave, the children are affected. We are also having seen so many cases of infection, minor infections is there. The patients are the young children have become positive, but the response of recovery rate is very high. Those are having minor symptoms, sometimes cold, cough and cold, sometimes having fever of 1 to 2 days. But the severe viral infection is less. And also in our experts from BGIs, they also advocate that the chances of the damage of the lungs below 10 years or below it should be minimum. But below 10 years, children have the more uh, uh, chances of less severe or less chances of hospitalization than that of the age of 10 years. So viral infection should be there, but the chances of damage or chances of the severe infection, chances of hospitalization is less in cases of less than 10 years children and more in cases of adolescent group is there.
So thank you very much, sir. I could not find any other questions. So with your prior permission, we can play a short video of less than 2 minutes for our product.
Yeah.
So, sir, if you unshare your screen so that we can share our screen.
Yeah.
So, Uma Shankarji, you can share that.
Yes.
Shield Healthcare, transforming health with innovation and technology.
Uma Shankarji, voice is not coming.
Indian Health and Wellness Award next to thank you for helping us achieve through valuable partnership. Health issues like recurrent respiratory infections can cause complex physiological and biochemical changes leading to ambulatory condition. Therefore, we need a specific immune booster to strengthen the respiratory.
Video is not coming.
Yes, just.
Shield Healthcare, transforming health with innovation and technology, is the winner of the prestigious Indian Health and Wellness Award. Likes to thank you for helping us achieve through your valuable partnership. Health issues like recurrent respiratory infections can cause complex physiological and biochemical changes leading to ambulatory condition. Therefore, we need a specific immune booster to strengthen the respiratory immunity. So, introducing Rudimin Mu tablets and Rudimin Mu syrup to strengthen the respiratory immunity. Rudimin Mu tablets and syrup are a specific combination of 4 bioactive ingredients along with immunovitamins and minerals. The bioactive ingredients are tinocoridin, curcuminoids, Asimenin, Osimum sanctum. Rudimin Mu is also enriched with immunovitamins like vitamin A, vitamin C, vitamin D3 and minerals like zinc and selenium. As per ESPN guidelines May 20, daily allowance of vitamins, minerals and trace elements maximizes nutritional defense for patients susceptible to frequent respiratory infections. Therefore, please prescribe Rudimin Mu tablets and syrup in recurrent respiratory infections. Only Rudimin Mu strengthens the respiratory immunity. Dose of Rudimin Mu tablet is 1 tablet BID. Dose of Rudimin Mu syrup is 5 ml BID. Doctor, Rudimin Mu shields immunity. Thank you.
Thank you, sir, for your valuable time in our platform. And
so the indication of Rudimin Mu is not for the acute cases of ARI. It is the basically Rudimin Mu should be given to those cases of having chances of recurrent respiratory infection. Those patients are very malnourished and having recurrent episodes of ARI, recurrent episodes of bronchial asthma, recurrent episodes of ARI. Those patients should be treated priorly, not in the cases of acute inflammation or acute condition. It is that basically to immunity, if you cannot generate immunity by a single drug or single day, this is the basic principle is not you have to increase the respiratory immunity from prior that of infection, before the infection. So basically, it should be given before the verge of third wave, not during the period of third wave, to tackle that situation.
Thank you very much, sir, for your valuable suggestions and nice discussion on this topic. So in future also, we will look forward some valuable session from you. And once again, sir, thank you for your valuable time in our platform. So thank you, sir, and have a good day, sir.
Thank you.
Sir, I mean, Minmoy.
Goodbye.
Sir, thank you. Thank you very much, sir. And also thanks to Suman Saha, sir, and also Umasankar, sir. Thank you, sir. Thanks to give that time. Thank you.